Osama graduated from our stroke fellowship at UT Health in Houston, and he's been running the stroke center, the doctor's hospital in Laredo. So he's in a very underserved area of our state and our country. He's taken a very active interest in this area and this topic. So he did a lot of research into the area of how GLP-1 agonists, well, they're taking the world by storm in obesity and diabetes, but they've also potentially shown benefits in cardio and cerebrovascular disease. So Osama, thanks so much for putting this together.
Thank you so much, Dr. Savage, for allowing me to talk on this topic. So my topic is GLP-1 agonists, cardiovascular benefits, and emerging potential in neurology. So disclosures, I don't have any disclosures. These are a class of medications that are used to treat diabetes and obesity. Briefly, broadly speaking, just on a big picture level, they work by reducing serum glucose levels and thereby helping the metabolism in patients who are afflicted with diabetes or obesity. And they have been here for a long time, and each subsequent generations of medications have gotten better and better. Byetta was the first GLP-1 agonist, which was approved in 2005 for the treatment of type 2 diabetes. And then subsequently in 2014, Saxenda, which is liraglutide, was approved specifically for weight loss. It was previously available for diabetes as Victoza. And in 2021, Wegovy or semaglutide also received the same indication for treatment of weight loss. And if you remember, in the 2020, 2021, it became very popular on social media, and a lot of stars and even Elon Musk, they started taking, semaglutide for weight loss. And I think that's how we're kind of, at least from my standpoint, I kind of got more interested in learning more about these medications, as a lot of people were having really good results on these medications. Other types of GLP-1 agonist includes dulaglutide, lexanatide, and tirzepatide. Tirzepatide is Mounjaro, which is the latest GLP-1/GIP-1 agonist. It's a dual agonist. And we'll talk about it in a little bit later. So these agents fall broadly into two categories, the one with a human GLP-1 backbone and the other ones with an exendin-4 backbone. The human GLP-1 backbones includes dulaglutide, liraglutide, albiglutide, and semaglutide. Semaglutide also is Ozempic or Wegovy. The ones with the exendin-4 agonist includes exenatide, lexanatide, which has been discontinued, and tirzepatide, which is like a dual agonist, GLP-1 and GIP-1 agonist. So this is a paper from in Cell Metabolism. It's a review. It's a basic science paper. Basically, it goes through how the GLP-1 agonist acts and their proposed mechanisms of action. Basically, GLP-1 agonist is secreted by the enteroendocrine cells in the intestine at low basal levels, and the levels rise basically after you eat food. What they, broadly speaking, they do is they reduce glucose-dependent insulin secretion, and they inhibit glucagon secretion in the islet cells while minimizing hypoglycemias. Okay. So again, as I mentioned, the GLP-1 agonists bind to the receptors on the pancreatic beta cells, which lead to the release of insulin. This helps to lower the blood sugar level. They inhibit glucagon secretion that prevents a rise in blood sugar levels. In addition, these also slow down stomach emptying that leads to earlier satiety and feeling of fullness, and overall reduces the food intake. But that's not the only mechanisms of action for the GLP-1 agonists. GLP-1 agonists also have central CNS effects as well. They have multiple areas of actions within the brain, like including the hypothalamus, where they will reduce food cravings and also will reduce the feeling of pleasure associated with food intake. And that's also in a way helps. That's in my anecdotal experience in speaking to patients that I see, that they have expressed that that's what they feel, that they don't feel any pleasure after eating food, and they just feel full and they don't want to eat anymore. This is just basically telling about what the GLP-1 agonists do. They activate the beta cells to increase insulin secretion, insulin biosynthesis, and decrease apoptosis. They will reduce the glucagon secretions. They will increase the pancreatic enzyme secretion and pancreatic protein synthesis. Of note, this paper mentions several basic science studies where they use the earlier generation of GLP-1 agonists, and in mice they were able to get recovery of the number of the islet cells in the pancreas. However, one limited clinical study that was done that did not demonstrate any improvement in islet cell density in humans. So while in rodents and rats, like they might help in recovery of pancreatic function and potentially treat their type 1 diabetes. In humans, there has been no benefit, at least in a limited study that was done to see if it affects the islet cells or not. It doesn't help in recovery of the islet cells. So one of the things that has always intrigued me after bariatric surgery was, like, the patients do lose weight, and is it just because it's the mechanical aspect that your stomach is smaller, or is it something else that happens as well? And so this paper tells us that obviously it's part of it is your stomach is slow, but also that there's an increase in GLP-1 secretion by the enteroendocrine cells following Roux-en-Y gastric bypass or a vertical sleeve gastrectomy, and so there's an increase in beta cell function and hypoglycemia, and there is an increase in insulin sensitivity. There's an increase in weight loss. There's an increase in bile acid as well. Okay. Another interesting aspect of the GLP-1 molecule itself and the GLP agonist is their ability to reduce inflammation. So how they reduce the systemic inflammation is not clear, but GLP-1 itself and the GLP-1 agonist, in the basic science studies, they demonstrate they reduce intestinal inflammation. Once the GLP-1 binds to the GLP-1 receptor, there's decreased intestinal inflammation, and the inflammation can be triggered by anything. It can be triggered by proteins, bile acid, endotoxins, lipopolysaccharides, short and long chain fatty acids. But in addition, as I will go further again, GLP-1 agonists, especially semaglutide and tirzepatide, they do reduce systemic inflammation, and that has long-lasting consequences for the patients, and that's an interesting aspect for us to look for when if we do potential trials for specific stroke patients in the future. So this is a meta-analysis published in 2018. This was when Mounjaro was not on board, but semaglutide was. It included trials which included a Lixa trial, which was a lexanatide, a leader trial for liraglutide, Sustain 6 for semaglutide, and Excel trial for exenatide. This had 33,457 patients, and they found was that there was a significant reduction in all-cause mortality as well as cardiovascular mortality compared to placebo. We will break this down a little bit further among the different GLP-1 agonists, because not all GLP-1 agonists are created equal. When long-acting agents were analyzed, there was a reduction in major adverse cardiac events as well as non-fatal strokes also, and that there was a trend towards significance. So this basically demonstrates, primary outcome. Basically, primary outcome was death from cardiovascular causes, non-fatal MI, and non-fatal strokes in these trials. And as you see, lexanatide doesn't demonstrate much of a difference. Liraglutide does demonstrate an improvement in primary outcome and all-cause mortality as well as cardiovascular mortality. The Sustain 6 trial, which included semaglutide and had around 3,297 patients, the primary outcome for overall first occurrence of death from cardiovascular causes or non-fatal MI or non-fatal strokes, it was superior. Exenatide did not demonstrate differences. So again, the molecules are getting better. The GLP-1 agonists are getting better with time. What aspect of the drug is getting better? Not clear. But compared with the earlier versus the later GLP-1 agonists, this includes semaglutide and Mounjaro, they seem to have a better outcome in terms of in terms of death from cardiovascular causes, non-fatal MI, and non-fatal strokes. This is another chart from the same meta-analysis, and it demonstrates that how much, if you look at Sustain 6 trial, I mean a 2.9 kilogram reduction in body weight, a 4.3 kilogram reduction in body weight for the 1 milligram group, similarly a significant blood pressure reduction in both groups for 0.5 and 1 milligram. So again, imagine, you're losing significant amount of weight. Like for example, semaglutide, you can lose up to 15% of body weight based on the clinical trials, and Mounjaro up to 25% of body weight. So you're losing all that weight. Obesity itself is very pro-inflammatory condition. So once you lose the weight, your blood pressure gets better. Your blood pressure gets better. Your diabetes, if you have diabetes, that gets better. All of those, in a way, downstream effect should theoretically help with reduction in stroke risk. So, so this is an other trial that was published in 2023, and it studied semaglutide and cardiovascular outcomes in obesity without diabetes. It was published in NEJM. It was a multi-center, double-blind, randomized, placebo-controlled trial that was event-driven. It was a superiority trial. About 17,604 patients were enrolled. 41 countries were involved, and there were 804 sites. So it was a pretty big trial, and this is called the SELECT trial. So the inclusion criteria was patients had to be 45 years or older, had a BMI 27 or greater, should have had established cardiovascular disease, and cardiovascular disease was defined as previous MI, previous stroke, or peripheral arterial disease. This trial did not include patients with diabetes. So if you had a previous diagnosis of diabetes, or if your A1C was 6.5, or if you had been treated with any glucose-lowering agents or a GLP-1 agonist even in the past 19 days, you were out of the trial. Also, if you had heart failure or end-stage renal disease or dialysis, and patients could not be enrolled within 60 days of a cardiovascular or neurological events, or if they were going coronary artery stenting, carotid artery stenting, or peripheral, any bypass or peripheral stenting. So patients were randomly assigned in a 1-to-1 ratio without stratification to receive a once-weekly subcutaneous dose of semaglutide with a dose of 2.4 milligrams, which is the max dose that you use. So the patients are initially started at 0.25 milligrams weekly, and then this dose was increased every 4 weeks. If you look at the product insert, it's the same way. Whenever you start semaglutide, you want to start at 0.25 and you go increase the dose every 4 weeks till you reach the max dose, or the patients develop side effects. If the dose led to unacceptable adverse effects, the dose escalation intervals could be extended, or treatment could be paused, or the maintenance dose could remain 2.4 milligrams per week. So unless they did not tolerate it, patients would remain in the trial. So the primary cardiovascular endpoint was a composite of death from cardiovascular causes, non-fatal myocardial infarction, or a non-fatal stroke assessed in a time to first event analysis. They had several confirmatory secondary endpoints as well, assessed in a time to first event analysis, and they were tested in hierarchical order. So they were death from cardiovascular causes, a composite heart failure endpoint, or death from any cause. So this is kind of like a busy trial, but the baseline, if you look at the baseline characteristics of the patients, average age of 61, a majority were Caucasians, but there were a significant Hispanic population, like around 914 patients on the semaglutide group and 908 in the placebo group. And I think, especially in Texas, that's kind of an important consideration as well. Body weight was around 96 kilos, BMI average was 33. And then, cardiovascular criteria, they had patients with myocardial infarction, stroke, peripheral artery disease. Average LDL was 78, so not that significant, significant elevations. Average blood pressure goal was around, average blood pressure was around 130s. So if you look on the right side, so this is where the primary cardiovascular endpoint comes. And if you look at it in this first on A, it's the primary composite cardiovascular endpoint semaglutide was for superior, and overall there was a cumulative decrease in percentage of events as time went on, and there was also a benefit in other death from cardiovascular disease, heart failure composite endpoint, and death from any cause, even though it might not have been significant, but it did favor semaglutide. Okay. So this is another chart, and again, as we see, there's a significant p-value from a cardiovascular endpoint, and a confirmatory secondary endpoint. Like again, while it wasn't significant, it did favor the semaglutide group. Okay. So again, there were some secondary endpoints. For example, if you look at the weight loss, just looking at the weight loss, there was a 9% weight loss over here, significant reduction in waist circumference. But the important thing I want to point out is if you look at the high CRP level, so there was a 39% reduction in CRP level. Now, this 39% reduction in CRP level demonstrated that a lot of these people were very pro-inflammatory, most likely as a result of their obesity and metabolic syndrome. But the important part is that the only thing that comes close to this level of CRP reductions are statins. And statins, they can have up to a 60% reduction in CRP. So these medications, apart from having additional benefits of weight loss, improvement of blood pressure, including diabetes, having a significant CRP level, in my opinion, I think that is a really big deal, and that would I think that would explain some of the reduction in cardiovascular events that we are seeing in this trial. So patients did have some adverse effects. This includes cardiac disorders. They were mostly tachycardias that patients had demonstrated. One of the concerns that people have with the GLP-1 agonist is medullary cancer. And that's only been seen in animal studies. There's been no clinical case of patients developing medullary cancer while being on GLP-1 agonist. And in this trial, the reduction, the occurrence of malignancies and neoplasms were pretty much similar. So it was a non-significant, so it was equal in both in the semaglutide group and placebo group. So I think like one of the things that people have a concern while prescribing GLP-1 agonists is, hey, a patient will have a risk of cancer. But I think we also have to look at, what's the higher chance of patients dying from? The patients will have a higher chance of dying from hypertension, diabetes, hyperlipidemia, obesity, sleep apnea, and the medullary cancer is also already a very rare cancer, and that chance is like, very, very low. So basically, with this, in this trial, in the STACK trial, they concluded that patients who had pre-existing cardiovascular disease but without diabetes, weekly semaglutide was superior to a placebo in reducing the death from cardiovascular causes, including non-fatal MI or non-fatal stroke, at a mean follow-up of 39.8 months. Okay, so this is another meta-analysis that was published in March 2024, and this included 13 randomized controlled trials with 30,512 patients. They went through multiple databases, including PubMed, Cochrane, and MBIS database, and then they used a random effects model in this meta-analysis. Okay, so basically, first of all, they looked through different randomized trials, including those comparing with placebo, and they enrolled patients. They then selected those trials in which patients were obese but without diabetes, and then at least one outcome of interest needed to be reported on those trials. So if there were non-randomized trials, if there were overlapping populations that did not report the outcome of interest and were duplicate publications, they were excluded from this meta-analysis. So there were multiple outcomes of interest. So there were systolic blood pressure, diastolic blood pressure, unstable angina, stroke, atrial fibrillation, myocardial infarction, and deep vein thrombosis. And then they use a subgroup analysis to analyze the impact of each drug. So out of all the studies, ultimately 13 studies were included in this. So again, looking at this figure, they are trying to figure. This figure shows so how much was the change in systolic blood pressure in these trials. And if you look at that, they have the liraglutide, semaglutide, tirzepatide, and there's a trend towards favoring GLP-1 agonists with significant reductions in blood pressure with these agents. Okay, so this shows myocardial infarction in the overall population and subgroup analysis. So again, these trials, it's kind of neutral overall benefit. It's kind of there's some favoring of GLP-1 agonists, but overall kind of remains close to the neutral side in terms of effect based on the meta-analysis that the authors did. Okay, and in terms of overall stroke population, overall stroke and incidence, again, again, several trials, only one trial for tirzepatide, and that again, kind of a neutral effect on this. So one would assume that with tirzepatide, I'm going to talk a little bit more about the amount of weight loss and effect it has the significant amount of diabetic improvement it has. You would assume that it would be more benefit. It will have a more trend towards lesser chances of cardiovascular events, but overall kind of neutral effect. So atrial fibrillation, overall, some benefit in semaglutide and liraglutide as well as tirzepatide, but mostly kind of we are staying kind of in the neutral territory in terms of effects. So the authors concluded that in patients who were obese or overweight, while GLP-1 reduced systolic blood pressure and the occurrence of myocardial infarction, there was a neutral effect on unstable angina, strokes, atrial fibrillation, and DVT. And that's very interesting because last year the AHA updated their guidelines, and for AFib management, in terms of the volume of AFib and treatment of AFib, they do now recommend GLP-1 agonists for weight loss. And by having the weight loss, at least from the AHA standpoint, it will reduce the burden of AFib, and it will reduce the incidence of improve the quality of life in patients with AFib. So this meta-analysis, while it's in 2004, I would say I would be kind of not agreeing with their recommendation whether it's a stroke or the AFib. This would not have a beneficial effect, because I think we need to have some better trials dedicated for those specific agents. So that was vascular neurology. So again, GLP-1 agonists, we're still studying those agents, and not only in vascular neurology, there is a big potential in general neurology as well. In general neurology, we see multiple conditions like diabetes, diabetic neuropathy, idiopathic intracranial hypertension, and with these agents promoting weight loss, reducing systemic inflammation, folks have started thinking towards, hey, what else can we consider GLP-1 agonists for? And this was a small study that was done, which demonstrated that GLP-1 agonists do reverse morphological abnormalities in diabetic peripheral neuropathy. These patients, had 22 patients in this, and they used ultrasonography and measurements of tibial nerve cross-sectional area to see what was the response before and after the start of GLP-1 agonists. And the GLP-1 agonist in this study was semaglutide or dulaglutide. So before starting treatment, there was a pathological increase in nerve size in 81.8% of the treatment group. After 1 month of follow-up, there was an improvement in nerve size in 86% of the participants, and in 32% of the participants, they returned to normal. In 3 months, there was a further increase in improvement in nerve size in 93% of the patients, and they had reduced severity of neuropathy and improved sural nerve conduction amplitude. So they did not, specify in this study, like when they said severity of neuropathy, like, was it just numbness, pain, tingling, what was exactly? But they demonstrated that overall patient satisfaction score, that the neuropathy was improved. So this study is small, but it does demonstrate that GLP-1 agonists do improve nerve morphology and structure, and further studies are needed to demonstrate a quantitative improvement, as well as correlating that to clinical improvement as well. And we do need dedicated clinical studies for neuropathy assessment in the future, especially with our large population of diabetic patients who have neuropathy. So another kind of my interest was to see if there was any data out there for patients with idiopathic intracranial hypertension. Now, most of these patients with idiopathic intracranial hypertension are morbidly obese, and we do know that a reduction in weight correlates to improvement in opening pressure. So that's one of the things that we do. Counsel patients, as in generalology, try to lose weight. But before, we did not have any good options. Now, with these medications, we have good options, and we can work with the patients to see if we can direct them towards greater weight loss, with the ultimate goal to cure their idiopathic intracranial hypertension. This was a study that I found. This was published last year, and it was an open label signal setter study. Basically, patients had a BMI of 30 or more, and they got a semaglutide or liraglutide in addition to the usual weight management. And the primary endpoint was percentage weight loss at 6 months compared to baseline. In addition, we had secondary endpoints as well, which includes how many monthly headache days the patient had, what were their visual outcome parameters, and their adverse events. So there were 39 patients in the study, and 13 patients were treated with GLP-1 agonists. At month 6, there was a greater reduction in weight loss as expected, around a 12% reduction in weight loss. And there was a mean headache days were significantly reduced in the GLP-1 agonist group compared to the placebo group. However, interestingly, the visual outcomes in this study did not change much compared to baseline. However, there was a reduction in acetazolamide dosing in the GLP-1 agonist group, which you would expect, as your intracranial pressure reduces, you'll need less acetazolamide. But the thing that I was really surprised was that the visual outcome parameters were not improved. And the adverse events were mild, but they did not lead to premature treatment discontinuation. So for me, I'm really excited about tirzepatide or Mounjaro or Zepbound. These are kind of the different brand names, because in clinical trials, they have the greatest weight loss, like around 25% weight loss. And now it has recently been approved for sleep apnea as well. And so the way I think about it is the way overall GLP-1 agonists work, but especially tirzepatide, you can have a better lipid profile, you'll have more weight loss, you'll decrease inflammation, your blood pressure is improved, sleep apnea is improved. Sleep apnea itself, is a very pro-inflammatory condition in addition to obesity. And then you get in a vicious cycle where, you're not, unless you lose weight, your sleep apnea is not improved. So I think tirzepatide comes in all of these, affects all of these things. And then obviously there's an improved AFib burden, especially if you lose weight, your AFib burden is going to get better as well, because there's less strain on the heart. And then obviously you'll have ultimately, theoretically, if you go down the pathways of second and third order effects, there should be a reduced risk of stroke, both primary prevention, in terms of primary prevention and secondary prevention. So in terms of vascular neurology trials, there are a couple of ideas that I have. I want to float out to the group to see if somebody's interested in taking this on, and kind of even working with me to see if we can get some of these things started. But having a dedicated stroke trial for both primary prevention and secondary prevention, and then seeing the effects of GLP-1 on atherogenic dyslipidemia, with a specific emphasis on tirzepatide, because I feel that that's the latest one and that's the most effective medication that I've seen. in terms of, we do know that plaque inflammation is associated with greater embolic events. This includes both carotid plaque and intracranial atherosclerotic plaque. We can consider a study to use the GLP-1 agonist, especially to study carotid plaque inflammation and its response to this agonist. In terms of general neurology, again, trials for dedicated trial for IIH, again, I said up to 25% weight loss, which is a significant weight loss, and some Mount 4 trials. We have data out of Australia where bariatric surgery literally cured, idiopathic intracranial hypertension associated with significant reduction in opening pressures in patient IIH. So again, this would be something I think would be really helpful. Again, diabetic neuropathy, as I mentioned, clinical trials right now are going on for Alzheimer's disease, for GLP-1 agonists. And then there was a recent trial that was published in 2024 about, it was a limited trial, but they felt that in early onset Parkinson's disease, there was a slowing of motor deterioration in patients with GLP-1 agonists. They used lixisenatide in that trial. But again, I said this would not just be applied for Parkinson's disease. Maybe it will be applied to other neurodegenerative conditions, because these medications do kind of reduce inflammation, including, I think, CNS inflammation. That would be something that would be able to consider. In terms of my own kind of personal experience, I'm a neurohospitalist, so I don't prescribe these drugs directly, but I have, seen, I have, worked with my colleagues who are on these medications, including people in the hospital and in my own community, and I've seen significant improvements, in their comorbid status, including diabetes, blood pressure. As an example, one of my, friends over here, he's like 30 years old. He wasn't obese, so he's a little bit overweight, but he's on 3 antihypertensive medications. We decided, together, he talked to me. I'm like, okay, why don't you try, going on Ozempic? And he went it, and he lost weight. With that, his blood pressure got improved. And as a result, imagine you're 30, 35, you're on 3 blood pressure medications, and blood pressure is not going to be adequately controlled all the time. But if you're off the medications, long term, your chance of having a stroke reduces significantly. It doesn't reduce to 0, but it does reduce. So I think these medications are kind of should be a public health priority to try to control the comorbid factors. And I think that, if they do become, public health priority, and a lot of people are able to get them, insurance covers them, I think we'll see a significant improvement in risk factors. We'll see a significant improvement in body weight. We'll see a significant improvement in obesity. And as neurologists, in general, both general and vascular, I think I would request our outpatient colleagues to at least consider these medications in part of their prescribing practices. Mostly the primary cares will do it, but you'll be surprised a lot of primary cares just don't want to deal with that. Basically, they will not prescribe them. But I think if patients coming to us with stroke, they already have had a stroke. Most likely they have diabetes. So, I think we should really push for prescribing of these medications. Thank you. Any questions?
Thanks, Osama. It's just great. It's really exciting. I think Ali has a question.
Let's see.
Thank you very much. Thank you for the talk. I was just going to ask you as well, the American Academy of Ophthalmology puts these medication as potential risk for, mainly increased risk for non-arthritic optic neuropathy as well, like NION.
Mm-hmm.
I'm not sure if you found any of that in the literature. I think from looking at their literature, they don't know whether it's association versus causation, and it's mainly in patients who are diabetic, as far as I recall.
Yeah, I think that's a good question. I think that I did recall seeing something regarding that a couple of months ago in Medscape. At least far as I know, the medication is usually contraindicated if you have diabetic retinopathy, as it can worsen your vision. And yes, at this point, I'm not sure if it would be causation versus, association. Yeah, I mean, and to be honestly speaking, if you look at the overall cohort of side effects, I don't think that that is very, very common. That's kind of like a very, very rare side effect.
And and this is also hello, could you hear me?
Hey, go ahead.
Yes.
Go ahead, Oleg. Go ahead.
Yes. Actually, for this NION, it's also important to consider obstructive sleep apnea, because we know these patients can wake up blind, right, with obstructive sleep apnea. And now we see this interrelationship between obesity, obstructive sleep apnea, and we have medication to help with obstructive sleep apnea now from this group as a bound. So it will be very interesting to really observe and maybe do the trial, but it's kind of difficult to predict if it happens. But we know this coexist, obstructive sleep apnea and optic neuropathy, non-arteritic optic neuropathy.
Interestingly, regarding the sleep apnea, like if you review the SURMOUNT trial data for sleep apnea for tirzepatide, it's very, very impressive. And it's like up to 50% reduction in apnea-hypopnea index, and that's for patients with moderate and severe sleep apnea. So it means that if you're moderate sleep apnea, there's a chance that you can become mild or even be cured of the sleep apnea. Whereas if you have severe sleep apnea, you can go into the moderate range. So again, it's not only a benefit of the quality of life, but a reduction in the intensity of treatment for the sleep apnea based on these medications. And if you look at the trial, they are not convinced that entirely this is just weight loss. There is some central effect as well that this medication has that's contributing to the reduction in AHI for these patients.
Yeah, that's true. That's true. We're just gaining the clinical experience because it just got approved. And the typical rule of thumb was that if you lose 10% of the body weight, you reduce apnea-hypopnea index by 24%. If you lose 20% of body weight, apnea-hypopnea index goes down about 50%. So that makes sense, and we knew about that fact, and we just want to see how it works in the real world.
Oleg, so you're both sleep and stroke, expert leader. So are you starting to prescribe this medicine for your patients?
Yes, it's a moderate to severe obstructive sleep apnea with intolerance to CPAP. Now we can do it. So far, it's not on formulary, and we have to find ways around to get it. I think eventually it will make up to formulary, and like Medicaid, we have a lot of Medicaid population here, and hopefully very soon they will adopt it, and we will reach out to our population. So far, commercial insurances they're approving.
All right, thanks, Oleg. It's pretty cool. Okay, there are more questions. Ty from UT Southwestern was asking, so Osama, I think this was a point, can they be used in subjects with normal body weight at lower doses?
I know, like the indication is like either you have diabetes or you have obesity and obesity related illness. So like if you have just normal body weight, you don't have diabetes, then at least so far, like there's no indication for that in that.
Okay.
This is again where the CRP question comes in, and systemic inflammation thing comes in. Like, so if you have a patient who has a stroke, is not diabetic but has hyperlipidemia or high blood pressure, is not obese, you have used the statins, the LDL is well controlled, what else can you do to optimize them? So that could be one subset of a population that could be considered, where we could measure their CRP levels, either get like a vessel wall imaging study, see if they have inflammatory plaque or something, and then use the GLP-1 agonists to see if that improves systemic inflammation. Because in my personal opinion, and my co-fellows, they kind of know my viewpoint on this, is that hyperlipidemia itself, I don't feel is the only thing that is like the be all end all for causing strokes and atherosclerosis. I think there is a strong inflammatory component to all of that. And then the fact that statins help significantly is because not just the lipid lowering effect, they also have a significant anti-inflammatory effect as well.
Another question. I think Farzan has their question up. Has a question.
Yeah. Hey, I missed the beginning of the presentation. A great presentation, by the way. I guess I've looked at the research quite a bit on these GLP-1 antagonists. It seems like most of these studies, the big confounding factor is weight loss. Have they done head-to-heads in medical fat or in gastric bypass, gastric sleeve, and see if the actual benefit is the drug? I know there is central effect. I know they're studying it in addiction medicine because there does seem to be a decrease in um, kind of addictive personality things or addictive things that are people are addicted to. They see it reduces gambling, stuff like that. So that's kind of my big question. I mean, because if we're having problems getting these patients this medication, since insurance may not cover it, Medicare and Medicaid, should you just get them a gastric sleeve or gastric bypass?
No, I don't think there's a head-to-head study with the gastric bypass itself. And the other thing I would add is that, we know that most patients with gastric bypass, gastric sleeves, they do recover their obesity weight. They do recover their weight, like in probably 10 to 15 years, they will have the recovery of the weight. One of the earlier slides I mentioned was that after gastric bypass, your GLP-1 agonists, GLP-1 levels do rise in the blood, and that also contributes to the weight loss and the decrease in systemic inflammation and the decreased appetite. So it's not just a mechanical, it's a neurohormonal alteration that happens, but unfortunately that neurohormonal alteration doesn't last that long. You do bring up a good point regarding the obsessive compulsive disorder. Again, as you mentioned correctly, now there are trials going on for obsessive compulsive disorder and even ADHD for this with these agonists. And anecdotally, what I've heard patients tell me, and I speak to a lot of patients, since I've been a very big proponent of getting these in my community, what they have told me was that people describe food noise, which they don't know they have food noise. But as soon as they start taking the medications, they feel like all their thoughts about food, they just go away. So I think part of obesity and part of all of these things is an obsessive compulsive kind of disorder inbuilt into the hyper obesity or increased food intake. And I think these medications kind of they block the dopamine receptors and they settle things down. So I think definitely there's a lot of reduction in food intake. I think it's not just because the appetite, that's it just really blocks the dopamine and food pleasure after eating food. And you'll be surprised, a lot of patients tell me, like one of my colleagues told me, he's like, I never knew I had food noise till I took the medication and then it went away. I'm like, my brain feels calm. Like I don't feel I need to eat or I have to eat, like unless I'm absolutely hungry. So I think, so again, I think we need to do kind of more studies, but I think again, they have broader sites of actions that what so far we know.
But I think the problem you run into with these medications is, at least the most recent data that I've read, is patients tend to have rebound weight gain and go even beyond their weight, the weight that they were their base weight, essentially. They go even beyond that when they stop this medication, and it seems like something that you would have to be on for life. Is that what you've seen as well?
Well, yeah, I mean, yes, this is a very common criticism for these medications. But then my counterpoint to that is, once you have high blood pressure, once your blood pressure becomes normal, once you start taking the medications, do you stop medications? You don't, because it's a lifelong condition. Similarly, obesity itself is an illness. It's a medical condition. It's not just you are overeating and stuff. So these medications, yes, they have to be taken lifelong. Patients will rebound weight. They will get even more weight once they stop the medications. But again, it is an illness. It's a chronic illness, and a chronic illness needs a chronic long-term medication. Now that choice is between taking one medication a week for the rest of your life, or starting with 2 or 3 medications, and in 10-15 years from now, once you have an MI, stroke, you have heart failure, renal failure, you're taking multiple more medications. So that's the way yes, these medications have to be lifelong. It cannot be like, hey, once you hit your weight, you can stop it, because obesity is a chronic illness.
So yeah, I guess
that's just Oh, sorry, go ahead. I was
No,
just
no, go
saying
ahead. You
thank you.
go.
I was saying thank you. I mean, that's why I wanted to see the head-to-head versus gastric sleeve, gastric bypass, medical fasting, stuff like that. Because there is some data out there that shows medical fasting may reduce your base weight set point. And that was kind of the point of what I was trying to get at earlier.
Yeah, but
It's a
I
good
agree with you. Fasting, so that might be a reasonable point, that the fasting itself can reduce your base set point, but it's not sustainable. Like, I mean, we have had no medication so far, like before Ozempic and Mounjaro came out, where you have a 15 to 25% sustained weight loss. Whereas, like, exercise fasting, you will have a 5% weight loss at best, and then you will have a rebound after that. With these medications, like, having a 15 to 25% weight loss, that's a very big deal. That's a big deal. And that has significant downstream benefits.
Definitely agree with you for sure on that point.
Thank you, Farzan. That's been really, you made some really excellent points. Certainly makes me rethink this. Yeah, so I guess my question is, so what do we need now? I mean, if anybody feels comfortable putting their stroke patients on GLP-1 agonists, it seems like, at this point, it's where the data leads you down, which is more about obesity, diabetes, than it is that there's an opportunity to reduce secondary stroke prevention separate from those risk factors. And so do we need randomized trials to really address these medications becoming part of our regular standard of care for our stroke patients, secondary stroke?
There seems to be very little downside to at least trialing it. Maybe the problem is obviously getting the medication covered. And you can go through compounding pharmacies, but even then, for some patients, $300 a month is not I guess $200, $300 a month is not something that's affordable. But at least in the short term, there doesn't seem to be much in the way of downsides for the treatment of if they have these chronic conditions.
I see. I think Naveen has her hand up. Naveen is from Cairo.
Yes, Sean, how are you?
Good. How are you?
Thank you. Well, I agree to what you said, because I got the impression that these medications, they reach their effect on stroke or cardiovascular events through reduction of obesity,
Right.
and consequently reduction of blood pressure when obesity is gone. And even in the intracranial hypertension, when the patient loses weight, the condition improves. So most of the effect is through reduction of obesity. So if we want to study it for prevention, secondary prevention of stroke, we need to study on patients who are not obese to see the direct effect on the risk factors, other risk factors.
So I'll just add. So it's, while the significant reduction in weight loss is one factor, it's not the only effect that these medications are having. Again, as I mentioned, there's a significant reduction in CRP as well, with systemic inflammation. So obesity and like sleep apnea, they're very pro-inflammatory conditions. So I think it also there's also a reduction in the CRP, overall systemic inflammation. So I think it's not just weight reduction itself. There are other mechanisms of actions on it in addition to weight reduction.
Which I guess you could test for if this was, a patient population that was not obese. You could look at testing some of those mechanisms.
Yeah.
Well, in the future, it most likely will become like aspirin. We will be giving.
I hope so. I'm praying for that day.
Yes, yes.
Like
it will be, because we have no problem with that antiplatelet therapy, be chronic, right? We now have these combos and different new agents coming, and same thing will happen probably here.
Maybe I know I have definitely a couple of patients who have gotten quite sick being on these drugs. And interesting. I mean, it's all GI side effects, but what I find interesting is that if people can tolerate them, they don't want to come off.
So interesting, Dr. Savitz. I'm not sure. I'm going to assume that your patients were on Ozempic
Yeah.
rather than Mounjaro. So
Yeah, they were on Ozempic.
yeah, so this is another anecdote like I have seen with the people that I have seen. I've seen a couple of same things as well. Like patients were on Ozempic and then they transition to Mounjaro. And what they tell me is that, Ozempic is like, it punishes you really badly, like a lot of GI side effects. And, if you eat something like very sweet or sugary, you'll vomit. Like you might not vomit today, but you'll vomit 2-3 days from now. It's really, there are majority of them still tolerate, but Mounjaro doesn't have that GI side effects. Like at least so far the people I've talked to, they're like, okay, we can eat a piece of cake or something and we'll be fine. We know we shouldn't be eating it. We eat a little bit of something, is fine. But with Ozempic has a very strong negative feedback mechanisms to high carb load diets. So I think that's why I'm more excited about Ozempic. Like Mounjaro, I'm more excited about Mounjaro. Like if their trials going to be done, Mounjaro might be a better one because it seems to be, at least in my anecdotal experience, seems to be better tolerated by patients.
I see.
Yeah, and this is probably same like disulfiram, when you do alcohol withdrawal, same thing. It's addiction, right? Mm-hmm. So it will punish you, like you said, because it's not supposed to happen, right? You should not have, you're losing weight, you're in a catabolictic state.
Mm-hmm.
Yeah. Okay. Farzan, you got another question?
Yeah, no, sorry. Just one comment. If any of our colleagues decide to prescribe this medication to their patients, just make sure to counsel them on maintaining adequate fluid intake. There have been quite a few patients who have renal failure because they completely lose their drive to eat, to drink, and so you want to make sure that you're counseling them and make sure that they're avoiding hypoglycemia, things like that.
And the other thing is, I agree, counseling them about fluid intake as well as protein intake. Like what I usually, tell people is that, eat small, frequent protein meals. And so that because you get filled earlier, but you want to have a good protein intake as well. So good fluid intake, good protein intake, just slowly, small amounts throughout the day. And then majority of the people do recover their ability to eat regular meals once they get settled on the medication in a month or so. Majority of people are going to be able to go back to, like, in terms of, they can regularly eat lunch, breakfast, dinner as they want to. But it takes a little bit of time as their body is getting used to the medication.
Got a question from Harris Kamal, up in the Woodlands.
Thank you, Dr. Savitz. Hey, Osama, great talk, and excellent discussions here. I had a question that how do you counsel your patients or about headaches, which seems to be another common complaint when we start these patients. The most amount of my patients have been on Ozempic, but migraine, especially those with a history of migraines, which is obviously a big percentage of the patients that we take care of, they tend to complain of literally headaches around the week or for at least the first 3-4 weeks. And mostly that's one of the other reasons for discontinuing these medications. So any particular advice besides hydration that you guys have been telling your patients for?
Thank you, Dr. Kamal. To be honest with you, I haven't heard of headache as a side effect, at least in an anecdotal experience with the people that are taking. But I'm going to be assuming that it's just because of dehydration and low fluid status. I think that's what I'm assuming. I think that's just going to be just kind of making sure that you're taking adequate amounts of fluid.
Got it. Yeah, sure. Thanks.
It probably also is the patient's not eating as much. We know most of these migraine patients, they get migraines when they don't eat. So making sure that they, again, like was mentioned earlier, to have these small meals, making sure that they don't become glycemic. Magnesium may help too, because a lot of these patients end up constipated initially.
Yeah, my understanding from patients.
Yeah,
I was saying the same thing that I've heard from some of my patients or from internists is that people are getting headaches. It's being told the reason is because we were all taught good hygiene was you're supposed to have 3 meals a day and stay hydrated. So I've been I don't know. I guess I'm being educated the same way on the same thoughts.
Yeah, the magnesium is an interesting thought, perhaps, worth a shot, because I think definitely that combination of constipation and just feeling, I think some of the malaise that initially some people have reported might help with
feeling lousy. Yeah.
Yeah.
Great. It's been a great discussion because I think we're going to hear more. The drug companies, it's such a blockbuster, so I'm sure there'll be more and more with regards to our patient populations. All right, I don't see anyone else for any further questions. No? Okay. Osama, thank you so much. Great talk, great discussion.
Thank you so much for having me. Thank you.